You're it. You're responsible all the way through college. If you didn't baptize that kid, you may not be on the hook for that. But somebody has to make a diagnosis. And again, this is a reminder that dentistry is no longer a solo thing. This is a team sport. So maybe you don't make the diagnosis, but you trigger the referral to a diagnosis. And based on the diagnosis, we're going to manage that person, hopefully correctly, but not always we're going to be right. I'm not right 100% of the times that I manage patients. And that's why the next step is to reassess, usually in cycles of between 3 to 6 weeks, because that's the time that takes for the mucosa to patch an ulcer. If I reevaluate a patient in 1 week, it may be too early for me to know that that epithelium already healed that ulcer. So I need about 3 weeks for that mucosa to patch itself. Otherwise, I may call my treatment a failure, but what happened is I didn't give it enough time. So 3 weeks statistically will not change the staging of any cancer or make a difference in the patient. And based on that re-eval, we are going to adjust our management, hopefully a little bit, but if we completely miss the boat, we can completely adjust our management. It's okay. And we keep doing that until the patient gets better or they die or whatever happens to the patient. Hopefully, good outcome, right? So we're going to talk about some of the traumatic ulcers. If you think an ulcer is traumatic, then the next logical step is to think of when you were in transitional kindergarten or kindergarten. When you were in the playground and a little piece of mulch went into your shoe, you didn't quit playing, you didn't put another set of socks, you just took that piece of mulch out of your shoe. So you removed the etiologic agent of the lesion, and then the lesion went away. Here is somebody that's pulling his own cheek. That's not my finger. And this person has a fully endorsed history of trauma to that mucosa. So this is a good bite on this patient, and that should clear up in a week, 2 or 3. But if you bring this patient earlier than that, say 5 days, that lesion will still be there, and we could erroneously call it a failure of treatment. This is another patient, much longer lesion, a little bit more concerning looking. This has the red center and the white halo, which is not what we expect in a typical ulceration. This is a special type of ulcer called TUGSI, or traumatic ulcerative granuloma with stromal eosinophilia. Very similar to a bed sore, in which the trauma has been so constant and so chronic that there has been damage to the striated muscle underneath. That myofiber degeneration induces the formation of eosinophils, or the migration of eosinophils into the tissue, and that halts the healing process. So this, just like a decubitus ulcer or a bed sore, is not going to heal, and it will ultimately need to be excised. So this is a TUGSI. Another couple of TUGSIs. Trauma that is chronic, low grade, persistent. And notice that in this case, we have flipped from from white center to red halo to the opposite, because this is no longer healing tissue. This is stuck in limbo. Another example of a patient that has a lesion, positive history of trauma. This person was on a vacation trip and they had a problem with chipping a tooth off. So they couldn't get out of that cruise. This is before COVID, and ends up with this chronic TUGSI on that lateral tongue area. Fix the tooth or take the tooth out, problem goes away. If it doesn't, we have to cut it out 3 weeks after. A couple of more TUGSIs just to give you an idea of how they look like. And here is another example of a traumatic ulceration. This is a 20-year-old female, so kind of borderline between pediatric dentist and early young adult, depending. But this is a patient that had bulimia, and every time that she will induce vomit, she will injure herself because she decided to grow her nails too long, and she ends up traumatized in that area. I see people sometimes with their nails that are so long, I don't even know how they clean their nose. It's pretty incredible. Or go to the bathroom. Or get out of the bathroom. Here's something I did my fair share when I was a dental student in the PROS clinic. Every time you do a denture, one or two areas in the flange are going to be too long. But these are traumatic ulcers that we know the cause of it. So just take the pebble out of the shoe and the problem should go away. This is another patient, history of a dental appointment approximately 1 week or two ago. And this is one time point in this lesion. This is the next appointment about a week and a half after. This is another traumatic lesion. It's called necrotizing cytometaplasia. And in this case, somebody injected a little bit too much anesthetic with epinephrine and induced ischemia and therefore necrosis of some of this tissue. And that necrotic epithelium and necrotic tissue sloughs off and creates this healing ulcer. It's very scary. Here's another traumatic ulceration. This is kind of like an ulcer, but also a burn. This is an institutionalized patient that has an ulcer of the floor of the mouth. This is a dementia patient. They get these little baby Dixie cups with 16 pills in it and another half a cup full of water or half full of water. They pop their pills in and then drink one of Dixie cups of water. One of those pills did not go through. It sat there and she said nothing. Nobody knew until she was in so much pain she wouldn't eat. And that's because a tablet got stuck in there and it chemically cauterized and burned that mucosa, which is a corollary of this talk. Dry mouth is a very critical issue. You'll see that all your patients that have dry mouth probably have 6 or 10 medications on their medical history. A lot of them will give you dry mouth. And then another little caution here about mucosal ulcerations. This is a patient with osteonecrosis of the jaw secondary to medications. This problem, many times I see, starts as a mucosal ulceration that was not managed in time. So somebody may have a palatal torus, somebody may have a denture that doesn't fit anymore and it has a pivot spot that it rocks, and that pivot area is going to ultimately become an ulcer. And if they have the medication and the propensity to develop it, plus they have the correct setting of microorganisms, etc., they could end up with necrosis of the jaw that induces an ulceration on the top. It's a little bit of the chicken and the egg, but I'll show you, I hope, a couple of other cases. Now, traumatic ulcers are very common, and because of that, we need to review how to manage this. I don't know what to do. I'll decline it. I feel powerful. So, one of the things that I want to make sure that I transmit is that if the ulcer is secondary to trauma, and after you remove the trauma, that ulcer should heal in 1, 2, or 3 weeks, the last thing we want to give that patient is a steroid. Because a steroid will delay wound healing. And if we do that, then this patient is going to have delayed wound healing. Therefore, in cases of traumatic ulcers, the 2 things that you have to do is remove the trauma. And second, if you want to, give the patient something to feel more comfortable, which could be either a little bit of Ora-based B, or maybe some Vaseline, or some salty water rinses. Salty water rinses, I learned this from Dr. Mizrahi in Guatemala. Salty water rinses are probably the best accessible bacteriostatic agent that we have. There's nothing wrong with salty water rinses, and it is wonderful for management of mild inflammation and bacteriostatic a little bit. So salty water rinses make the tissues be cleaner, and clean tissues heal better. Salty water rinses, very important. Teaspoon of salt, cup of water, lukewarm, not too hot, rinse and spit. Finish the cup, repeat twice a day. It should heal much faster. Don't swallow, because otherwise it will be an emetic, and that will not be fun. Now, removing the trauma is number 1. Number 2, patients that have traumatic ulcers many times have recurrent episodes of that occasionally because they have severe dry mouth. People with dry mouth will have a much higher incidence of traumatic ulcers because the mouth mucosa is not coated with the lubricant of mucus. And as the upper and lower teeth are chomping on that mucosa, it doesn't wiggle out of their way. It gets actually stuck to the enamel or the crown or porcelain or whatever, zirconia, and then it gets stapled in between the two teeth. And that is a consequence of their mucosa being too dry. So occasionally I will give patients a mouth lubricant. The best mouth lubricant I have found is olive oil. And so there are biotin products and all kinds of Salavasure and other commercial things that usually are based on carbohydrates, non-cardiogenic carbohydrates, but based on that. And in my experience, olive oil rinses are probably the best lubricant for the mucosa. And that allows for that mucosa not to desiccate and not to get in the middle of the teeth so it doesn't get traumatized. So lubrication and supplementation. Another useful thing for people with dry mouth to prevent trauma is the natural reaction for somebody who feels dryness in the mouth is to have a bottle of water and sit on the thing all the time, all day long. What they're doing, I found, is that they are washing away the coat of mucus, of the mucosa, and they basically make that epithelium not lubricated. And that makes them chew and bite on it traumatically more. So it relieves the sensation of dryness for about 5 seconds, and then it washes away. So better than that is to tell your patients to keep the water handy. When they feel thirsty or when they feel that their mouth is dry, take a good swig of that, swish it in the mouth to remove the frothy saliva, swallow that, and then keep swallowing water until they are satisfied of the thirst. Then they take a teaspoon of olive oil and they rinse it in their mouth for 30 to 60 seconds. Then they spit that in the trash. Don't tell them not to spit it in their faucet because it will clog their drain. So put it in the trash and then walk away. When they feel the need to do the same process again, do both. Water first, oil second. If you do it the other way, then the oil doesn't stick or you wash it away. And if they swish too much or swallow too much, they move out that low coating of the mouth. That is fantastic for people with CPAP machines, with sleep apnea, with people that sleep with their mouth open. They do that, and if they get up in the middle of the night to use the restroom, they do it again, and their mouth environment is going to improve dramatically. So just, it's not related to the ulcer concept, but it prevents ulcers and it makes them heal a lot faster. Okay, so these are 4 things that are good for traumatic ulcers. Benzocaine in any concentration, oral gel for babies, or topical that you have in your offices, whatever you want to use is fine. Viscous lidocaine rinses is excellent for people who have a whole mouthful of these lesions. So you can prescribe 2% viscous lidocaine, and the pharmacy will give them a little bit of viscous thing, usually about 30 mils, and they swish it and spit it. The longer they keep it in the mouth, the better it's going to numb that mouth. Orabase B is probably the most available thing, is a Colgate product, and the B stands for benzocaine. Orabase has an adhesive in it, and I'm going to give you a little bit of a tip on how to use this better. MBX stands for Maalox, Benadryl, and Xylocaine in equal parts. You call in a prescription. It's a compounded product, so they will actually charge the patient for a compounding fee, which is about $40, plus the cost of the medication. But when you recommend somebody using Orabase B or anything like triamcinolone paste or dental paste that has the adhesive in it, what you need to think is that this adhesive paste sticks to the driest thing that it comes in contact with. And the thing in the mouth that dries the fastest is ceramic, enamel, dentin, zirconia, and anything that's not mucosa. It will evaporate faster. It holds a much thinner coat of liquid around it, and the layer of fluid evaporates fast. Therefore, if somebody takes the oral base in their finger and they go in their mouth and they put it on their cheek or lip or tongue, as soon as they close their mouth, that oral base B is going to actually transfer from the mucosa that is wet to the teeth that are dry, and then they lost the effect of that. So to fix that, what you need to tell your patients is that they need to pick up a box of double-sided Q-tips when they pick up their oral base B. On one side of the Q-tip, they load it with oral base B. On the other side, they leave it dry. They expose the ulcer, they dry the mucosa of that ulcer gently, and then they flip the Q-tip and they paint that gently on that tissue and let it sit for 30 seconds, and then they can let go. That way, the adhesion is going to be maximized to the mucosa rather than going towards the tooth. So that's useful. MBX, also, they can rinse with it 30 to 60 seconds, PRN as needed and as often as they want. The xylocaine will numb it. The viscous lidocaine will numb it. I don't know if you have tried this, but I have the bad habit, I guess, of trying meds. And this taught me a lesson that I try to repeat as much as I can. So I tried, when I was in clinic, I tried viscous lidocaine. And I don't know if you have ever swallowed viscous lidocaine, but I just about freaked out because here's what happened. I swallowed the viscous lidocaine, it numbed my oropharynx, and my brain stopped sensing the feedback of coolness, air moving. My brain thought I was asphyxiating because I was not sensing the air going in and out. And I truly panicked. And I knew what I was doing, or I thought I knew what I was doing. But it was so scary that I panicked. Therefore, I learned that I never will swallow viscous lidocaine again. But I also, if I give this to a patient, especially pediatric patients, we have to educate them and tell them, you have to train yourself first. Do some water rinses and make sure you don't swallow anything. And if you do, have somebody near you with a glass of water, drink some water, and it will wash it off. But if it happens, it's pretty scary. Now, those of you who are adventurous, go home or go to your clinic and try a little viscous lidocaine or swallow a dollop of benzocaine and tell me how you feel afterwards. So, message is don't let your patients swallow that stuff because it's pretty freaky. It's scary stuff. Okay, so this is not ulcers, but Dr. Lopez was very curious about this, and he's been for a while. I don't know much about bruxism, but there is an epidemic of bruxism in kids who don't have video games and who don't have ADHD or ADD or things like that. I don't know, but I've seen tons of kids with bruxism. Anybody here sees more now than before? Any idea why that happens? COVID mouth? I don't know.
There's a hypothesis that says, like, I mean, when they're exposed to much LED light, like the
LED lights?
yes,
Uh-huh.
like the circun
Incandescent.
cycle
Or, yeah.
change, and that's why when they're sleeping, they still have that brain activity that make them.
Oh, that's interesting. I don't know. I'm gonna start checking on that because, yeah, I don't know, but there is a lot of that going on. I don't know why, but there's a lot of that going on. The other theory that I at some point read was that the tendency in the population was to have large BMIs, and with that there was thickness of the mucosa. I don't know if that explains it or not. I don't know if you've seen it in thin patients versus high BMI patients, but anecdotally, that's another of the things that I knew. Obviously, I don't know how to drive this thing. Okay, so here is a table of steroids, and I'm happy to send you an email or respond to your email with the actual prescriptions of these. but I wanted to cover this before the rest of the talk because this is what I use. I am not a very sophisticated practitioner of stomatology. I try to keep it as simple as possible, so I already know and memorize all of these meds, and I know how to prescribe them, and I know how to write them. But fluocinamide and clobetasol are gels. You want to use gels for the mouth. You don't want to use ointments. You don't want to use creams. They don't stick as well. Now, with the gel, they have a little bit of polyvinyl alcohol in it, and that makes it sting. When the patient first puts the clobetasol gel on that ulcer, is going to feel like you are swishing with wine or mouthwash. Is going to sting. So if you tell the patient that when they first put it on is going to sting a little bit, they will expect it and they will know and they will think you know your stuff. If you don't tell them, then they will think, and their parents are going to think that you don't know what you're doing because you gave that patient something that actually makes it worse. So tell them that it's okay for the first few days, that it's going to make it sting, but it will make it better. And that gives you credibility in with your patients and their families. So clobetasol is an ultra-potent topical steroid. Fluocinamide is a potent topical steroid. There's about 1 order of magnitude between one and the other. Clobetasol only used for 2 weeks at the most, and then you stop it. And you have to give that mucosa a rest of at least 2 weeks. Otherwise, the steroid is going to induce atrophy. Fluocinamide, you can use a little bit longer. I don't like gels in general for the mouth because what do you think happens to that gel?
You swallow.
They swallow it, correct. So I've had patients with diabetes come back with hyperglycemia that you go, where the heck did this come from? Courtesy of yours truly, because they are swallowing that thing. Therefore, I almost never prescribe them anymore unless I know the patient, I know their medical history, and I know they'll use it well. So dexamethasone is an elixir, and that is my favorite topical steroid by a country mile, or by an Edinburgh mile, or a Harlingen mile. Dexamethasone is a liquid. It also has approximately 10 to 20% of alcohol volume in it. Some of them are alcohol-free, and they sting less. But there's a little value in the cleansing action and dehydrating action of the alcohol that will make the steroid work better. So dexamethasone will also sting a little bit when they first use it, but it will make their mucosa feel a whole lot better down the line. Dexamethasone, the good thing about it is that being a liquid, it can be swished in the mouth. You don't need dexterity. You don't need to isolate the lesions. You don't need Q-tips. You don't need to even look at the lesions. All you need is to have enough volume in the patient's mouth that will pouch out the mucosa enough that you don't create any sealed areas. The usual patient that fails in dexamethasone elixir treatment is the person that swishes very daintily like this. If they swish like a fish, then they are collapsing the cheek to the gingiva, and then that liquid is not going there. So I tell them to swish like a puffer fish and to do this and have enough volume in their mouth that will allow it. And it's okay for them to tilt the head a little bit and do the little bobble head move because that will allow for that dexamethasone to go to all the places. I remind them that it will only treat the areas that it touches. And if it doesn't touch a spot, it will not treat it. That figure for pediatric patients is very useful, and so they will do that. Sometimes I combine dexamethasone with other things, knowing that I'm diluting the effect of dexamethasone, but a lot of my patients will have a higher incidence of candidiasis, so I will use dexamethasone with nystatin in different proportions. I started with half and half, and then I moved to 2-to-1 or 3-to-1 as needed. Tacrolimus is a beautiful medication that unfortunately still has, I think undeservingly, but still has a black box warning by the FDA that induces increased risk of oral cancer in some patients. But I use it occasionally as a last resort in topical patients that have recalcitrant aphthous ulcers or issues that I require immunosuppression without using steroids. So that's the left column. In the right column, there's lots of other things, and I'm going to unpackage that in a little bit because I want to show you some ulcers, which is what you are here for. So the first batch of ulcers I'm going to show you are ulcers secondary to infectious agents. Here is a tonsillar abscess. So a PTA is truly a medical emergency. This pus is probably going in there, and as you know, the interior carotid artery is just next door to this thing. So a tonsillar abscess is a true medical emergency. Most patients with a PTA need to be referred to ENT or the urgent care or ER relatively quickly, because if that abscess starts to dissect, it can go into the mediastinum and it be a big problem. So ulcers in the tonsil are never okay. The only time that I allow to have ulcers in the tonsil is if I have a history of trauma on that patient, or if I'm going to see that patient in 3 weeks. Other than that, if I see asymmetric tonsils or tonsils that make no sense based on the patient, because pediatric patients will have many times massive tonsils that touch in the middle, that's an exception. But in an adult patient, if you have an asymmetric tonsil with no history of infection or signs of infection in that area, like a PTA, then I will refer that patient immediately to ENT for imaging and biopsy. So here's another case that I want to show you. Here is the mandibular vestibule on this patient. This patient was probably, I'm going to say 24. I think it's a 24-year-old person. Now, is this an ulcer? Hard to tell, right? It's hard to tell. And the most common thing I do to lesions like that when I think they're an ulcer or I'm not sure is I'm going to scrape it, because I want to see if that fibrin comes off, if there's a blister or if there's something. It hurts. In this case, this is not my patient. This is a case that was shared with me from somebody else. I'm going to show you how deceiving this thing can be. So here is mandibular vestibule. Here is the palate. Obviously, those are not ulcers, and those things don't scrape off. This is the great imitator. And this patient has also these lesions in the anterior tonsillar pillar and tonsillar fossa, posterior tonsillar pillar. That is oral syphilis. So syphilis is on the rise. There is, just like there is morsicasio in kids, there is a lot of syphilis in adults, especially in 60 to 70-year-old patients, because of erectile dysfunction pills. So this cohort of patients that in the past would not have sexual activity, they are staying active and highly promiscuous until much later in life, and they end up with their immunosenescence, higher incidence of syphilis. So an oral ulcer, like the one you see up here in this picture, of course, this is a typical oral ulcer from a website, but ulcers that make no sense, that don't heal, or that heal and then come back, you need to think of syphilis as a possibility, because sexual promiscuity is very, very rampant in all ages. Here's another case of a patient that, this is not my case, it was shared with me. This is a very ill patient, history of breast cancer, and currently being treated for lymphoma and with recurrent ascites. So this is a very sick patient that went into the hospital and was probably not doing well, but ends up with this massive area of unusual looking lesions. Now, white center, a little bit of red halo. Okay, I'll buy that, but not a whole lot of red. I'm gonna come back to this. This is another patient with the exact same disease of the previous picture. I saw this patient in the hospital. I was calling in for an inpatient consultation for this kid. This kid was being treated for leukemia, wiped out immunosuppression, no immune system at all. When I came in, this kid was eating a bag of potato chips. What I didn't see is that on his arm was a morphine pump. But this kid and this person have the same thing. This is a reactivation of herpes simplex. But in an immunosuppressed patient, herpes will go everywhere it wants, and it will be very atypical presentation. So this is the viral cytopathic effect of herpes simplex that we are familiar with. So this is how atypical herpes will show up in a patient who has no immune system. So this virus is doing whatever it wants with this kid and potentially being very serious. Another case of an immunosuppressed patient. This is an acute myelogenous leukemia patient that's undergoing chemotherapy. And during induction, they have basically no immune system. So if these people have any history of herpes simplex, they will have a reactivation. And that's why all of these people end up with antivirals and antifungals as a prophylaxis for this. Here is a patient that had herpes simplex. This is the first time this teenager had herpes simplex. When teenagers have the first encounter with herpes, most of the times they're going to have a non-specific viral signs and symptoms complex. They're going to have fever, malaise, and pain, and oral pain. They won't know what they have. So what they do is they try to scrape it, scratch it, or squeeze it. Dr. Pimple Popper right there on YouTube. And what they could be doing is they will be seeding these to their nose or eyes or genitals if they actually happen to touch that or move it around. So patients with primary herpes are a patient that I will spend a long time giving them patient education and training about their issues because they can easily self-inoculate or inoculate others with these issues. Now, what I'm about to say is a sin to my infectious disease friends, but I still do it. If I see a kid like this, and it's been already 5 days of misery for this child, and they have been miserable, and their family is miserable, even though they already are in the crusty stage of their primary herpes, I will spend the time teaching them about herpes, telling them what it is, and if I don't feel that I got through, I may put them on antiviral medicines for a week or two because I want to cover other sites of this patient's body for self-inoculation, especially genitals and ocular. So I do commit sacrilege once in a while with antiviral medications in these patients. Another patient with primary herpetic stomatitis, most kids that have herpes in the pediatric population are going to have it near the front of the mouth because they either got it by biting their nails or by kissing somebody for the first time. And that is historically accurate, although, I'll show you here, this is an older patient that ends up with primary herpetic stomatitis after orogenital contact. And so when that occurs, the primary spot of infection is farther back after fellatio. So it used to be like that. Now, I've had a ton of patients that I encounter with these kind of things crossing the ages. And here is why. Because kids now don't consider oral sex sex. They don't think that having orogenital contact is sex. Therefore, they have unprotected contact with somebody that they don't know or they just met and end up with a gift that keeps on giving. Because just like diamonds, herpes is forever. Once it gets to your trigeminal ganglion, it will be there for your life. There is nothing we can do to remove it. It will be there forever. And it will just wait until that patient gets an immunosuppression episode to go back and give them a recurrent herpes labialis or intraoral herpes or ocular herpes or genital herpes. So I'm going to skip a couple of these herpes things quickly. I'm going to show you this that looks a lot like herpes on the lip. But this person has no history of herpes labialis. They do have a little bit of lesions in the mouth. Now, this doesn't look like herpes anymore. This is definitely outside. This patient is technically not immunosuppressed. And these are different areas of that. So of course, ends up in a biopsy of this patient. And I couldn't resist to put a little histology here for you guys. But this is a patient inside that epithelium, right in these areas here. Let me grab my pointer here if I can. Or not. Anyway, so in these areas here, I'm going to show you a higher magnification. These are larvae of worms. So this patient had worms in his mouth. Now this patient has this unusual lesion, and this patient also had some kind of transient immunosuppression. What you see in this patient's left buccal mucosa was very indurated. It was tender, but not as tender as you think it would be. This patient was taking biologics for RA. And what are biologics for RA? They're immunosuppressants. And when we give that to people for rheumatoid arthritis, Crohn's, IBS, whatever you find on the commercials on TV, the immune system of these people is going to be compromised. And when we have that, we can end up with somebody like this. This patient has histoplasmosis in the mouth. This is not common. Only about 500,000 cases in the US are diagnosed, usually in the lungs. But this is what can happen in somebody with immunosuppression. So your patients that you take their medical history and they list arthritis in there, you better ask if it's osteoarthritis or RA. If it is RA, you want to know what medicine they're on, or Crohn's, or IBS, or any of the different medications that are immunosuppressants. Patients with sarcoidosis can get different lesions, like similar lesions like that. So this is a patient that had AIDS, and this is a cytomegalovirus ulceration as well. So due to infections, all kinds of stuff can happen. Monkeypox is something that also needs to be in your radar as oral healthcare providers. We probably will be among the first providers that will see a patient with mouth ulcers or mouth sores. And if we ask the right questions respectfully and confidentially and privately, we might be the ones that trigger the workup for monkeypox. So it's very important. Carlos, how are we doing with time?
Good.
Keep going a little bit. Right. So now I'm going to show you a next batch of ulcers in pediatric patients and in adult patients. And these ones are secondary to immunologic dysfunction, either hyperactive immune system, confused immune system, or inactive or lazy immune system. So here is a patient that has this. This patient had an infection of his axilla. This is a Marine, and had an infection in his axilla. He was given an antibiotic for that, and it gave him this mouthful of pain and sores. This patient has erythema multiforme, secondary to a reaction to that antibiotic. Now, for us, this will be easy to link, right? So I took penicillin, I get a mouthful of ulcers. With crusty lips, probably EM. And we know what to do about that. But let me show you this person. I saw this person maybe a week and a half before Christmas last year, and she had this mouth full of soreness. So she, 23-year-old mother of three, single mother of three, this lady had those two things. Her story is that she has genital herpes. She ran out of her herpes medicine. Because she ran out of the herpes medicine, her genital herpes flared up. And that triggered an immune response that manifested clinically like this targetoid lesion and this mouthful of pain, which is, again, erythema multiforme, which I treated, but I didn't only treat it with a steroid. I gave her an antiviral as well. So I gave her a prescription for an antiviral, and I gave her 12 refills, and I told her, come back to see me every 6 months, and we'll make sure that you have this all the time. And this is how she looks like. Now, She's been back a couple times with flare-ups because she, again, runs out of antivirals, doesn't refill them, and ends up with that. The most common trigger for erythema multiforme that involves our area of concern is herpes simplex, either genital or oral. And she had genital herpes. This is another guy that also had genital herpes and ends up with this mouth thing. But if we don't connect the dots and ask these people their full medical history, then we will not know. And we potentially will be chasing the wrong diagnosis on these people. Crusty lips, ulcerated lips, intraoral disaster. So these people are usually dehydrated by the time I see them. They're sleep deprived, they're cranky, they're crabby. Usually they wait a long time because they come to a teaching institution, so they sit in their room for forever. And so these people are miserable. This is the kind of people that we can help if we ask the right questions. Any other body site involvement? Has this happened before? Do you get blisters before that? All of these questions will set you up for connecting the dots and reaching the right diagnosis for these people. And hopefully you'll be able to help them. Can you imagine eating like this? It's impossible. So what this guy did, the story of this guy is, he would just walk to the ED and get himself checked in. They will hook him up to a steroid drip, fix him up in a day and a half, then he walk out. And then he will get another one in and checked in every 3 to 4 weeks. And nobody ever connected the genital herpes to this thing. We put him on antiviral medicines, clear and no recurrences. Connect the dots, you'll help people a lot better. You don't want your patients to look like that. Another ulcer. Now this is an adult, and this patient, as you can imagine, was pretty miserable. This is one side of the tongue. This is the other side of this guy's tongue. Now that's an ulcer. But it's switched again. The whitish halo is in some places, but now I have a white halo around it. This is large. And as I show you the cheeks of this person, now you have a diagnosis. So now you have white stria, red center, white halo. This is not geographic tongue. This is lichen planus, but very severe lichen planus. This is the same patient. Look at this anterior here, and then this is, I couldn't tug him enough to take the picture. He was pretty uncomfortable, so I had to take it in 2 stages, but this is somebody with very significant ulcerative erosive lichen planus. This is the kind of person that we have to help. And how do we do that? Lichen planus is a diagnosis of exclusion. We never make the diagnosis of lichen planus without having ruled out all the mimickers of lichen planus. For example, lichenoid reaction to medications, lichenoid reaction to dental materials, lichenoid reaction to flavoring agents, lichenoid reaction to anything. So this patient had just started a new medication about 4 weeks before this happened. And we had enough suspicion that that was the case. We removed the medication, substituted with a different family of med, and he cleared up without steroids. The point of this case is that it looks like lichen planus, but if we do the homework before we label it, because we have to start assuming that it's a lichenoid response to something, we have to find the pebble in the shoe, remove that pebble, and then watch the lesion go away. If we fail at that, then I will label this patient lichen planus, and then I will give them a steroid to clear that off. But I'm not fixing his problem, I am hiding his problem. And that's not an ideal scenario. So this is another patient that I saw about a month ago, and I'm introducing these pictures one by one in a specific order that is not the same as I do my exam. I do my exam, and this is probably the same for you guys. Your oral head and neck exam should be just like your shower. My mom taught me to take a shower the exact same way every single day, sometimes 2 or 3 times a day, and I will start from the top to the bottom and wash everything. That way I don't forget anything. If I don't do it the same way every time, I will forget an armpit or some elbow or whatever, and then I won't be as clean. Therefore, if you do your head neck exams the exact same way to everybody all the time, you will have a routine, just like taking a golf shot or just like taking a shower. Same way, everybody, all the time. So here's one. Here's the other one. So far, so good. But this patient has a mouthful of sores. This is the top. This is the bottom. Now we're starting to see a little bit of red, a little bit of white. This, by the way, I, of course, tried to scrape off. And I ended up with a piece of her mucosa on the Q-tip I was using. This is the palate. And these are already erosive ulcerative lesions in her palate. This is her right buccal mucosa, and this is her left buccal mucosa. So this patient, after a biopsy or two, ends up having pemphigus vulgaris. Again, a diagnosis that we have to reach by exclusion because there is a condition called PAMS. Exactly. There's a condition called PAMS, which is pemphigus-like autoimmune disorder or syndrome. And I'm going to show you a case of PAMS in just a little bit. It used to be called paraneoplastic pemphigus. And it's when a tumor or a cancer is antigenically active in the patient's immune system detects that tumor, tries to make antibodies to that tumor, the antibodies circulate, and they cross-react with molecules in the mucosa, making them fail and slough off. So we have paraneoplastic pemphigus, paraneoplastic pemphigoid, paraneoplastic lichenoid lesion. So we have to be aware of that. Now, acantholysis is the process by which the epithelium dissolves by means of breaking two proteins, desmoglein 1 and desmoglein 3. When the antibodies made by the plasma cells go and attack these proteins, the chain that fuses one cell to the other is broken and the cells slough off. And that happens in this case. Now, those patients also require immunosuppression, and we usually give them systemic immunosuppression, Imuran, Celsep, etc., and IVIGs. I'm not going to cover that at this point. I'm going to try to keep it more clinically for you. This is probably another of the pediatric population patients you see a lot. This is aphthous ulcer. This is minor aphthous stomatitis. And again, this is a diagnosis that I only reach after I have ruled out everything I can. If I have ruled out everything I can systemic, and the lesions are still there, and the patient is still having the issues, and I have not connected any other dots, then I will use the label aphthous stomatitis or recurrent aphthous ulcers. So this lesion is an ulcer that has pseudomembrane in the center, erythematous inflammatory area on the periphery. This is in movable mucosa. Remember, this is different than attached to the bone. This actually was a dental student who had this massive ulcer. This is also the same lesion. And this is also a dental hygiene student that had a teeny tiny little ulcer that was exquisitely tender to her and to him and to her. All of these hurt a lot. These three happen to be recurrent aphthous ulcers. But before I label these people with RAS or recurrent aphthous stomatitis, you have to check for many other things. The most common thing is Crohn's or IBS and sarcoidosis. A lot of systemic diseases can show up in the mouth like ulcers. And AFT is a diagnosis of exclusion. So Crohn's disease and all these related disorders, sarcoidosis, anemia, also important, and anything with granulomatous inflammation like sarcoidosis or deep fungal infections play into this patient's presentation. This is a patient who had Crohn's disease. So this person had a linear area of induration with an ulcer down in here that waxes and wanes, but it never goes away. Very seldom they respond to topical steroids because this is granulomas. They have to be treated with much higher doses of immunomodulation. This is a patient that also had a systemic condition. This patient had IBS. And this lady was a fascinating case. This lady had ulcers on the tongue, ulcers on the lips, ulcers on the cheek. And she also had a little bit of dry mouth. Her problem was, it looks like aphthous or lichen planus or something like that. But her problem is she had bariatric surgery and she ran out of her vitamins and supplements. So she quit using them. Therefore, she became anemic. When anemia is severe, the diffusion of nutrients and oxygen to the epithelium is so compromised that the epithelium undergoes a defense mechanism that's very logical, which is atrophy. That atrophic epithelium is easily ulcerated, and at some point it may actually spontaneously ulcerate, which is what was happening to this person. This person was never going to get better with steroids. This person was not going to get better with anything. What she needed is to fix her anemia, which we did, and then the lesions self-corrected. So whenever possible, take the rock out of the shoe and the lesion will self-correct. This was an ortho resident that was being treated for myelodysplastic syndrome and ends up with candida and afti all over his mouth. And then I want to cover a little bit of peeling of mucosa that leaves an ulcer. And this is the typical patient that gets misdiagnosed clinically as having gingivosis or periodontosis or periodontitis or intractable periodontal disease or atypical periodontal disease, whatever permutation of terms. But this patient was having sloughing of tissue. And this is the lower, upper, and as you can see, there's something wrong with this tissue. So I take one of my favorite tools, a Q-tip, and I break it in half. I try to get one sharp edge in there, and I start digging. Because at UNC, the explorers we have are so dull, I cannot hook epithelium. I actually need a Q-tip cut well, and it actually hooks epithelium pretty well. So in here, I'm doing what's called a Nikolsky test or a Nikolsky sign. This is sloughing and doing this. So this patient is having, of course, all of this tissue. I'm peeling all that epithelium off, leaving a raw connective tissue, and she's in tears, and I'm taking pictures. And because I know I'll help her. But I love taking pictures of this kind of stuff. I'm gonna give you that. So this is the kind of patient that obviously needs a biopsy for diagnosis, for immunofluorescence, and at some point we're going to have a diagnosis of mucous membrane pemphigoid. So this patient has mucous membrane pemphigoid. Now, little word of caution about the ulcers that happen on top of bone. On top of bone, in patients that have history of anti-resorptive medications, you want to be very, very careful with that, because once you have an ulcer, the quote integumentary membrane of the mouth has been breached, and the oral flora will go in that hole, take refuge in the bone, and then that bone that is under the effect of denosumab or whichever bisphosphonate will not be able to heal and ultimately die. And that's what happens. This is a patient that had osteoporosis. She was on Fosamax and ends up with a denture. Here is the typical sequence that I see maybe 3 or 4 patients a month with this exact same problem. So they are osteopenic or osteoporotic. They go on bisphosphonate or Prolia or whichever one of the anti-resorptive meds. And then their denture no longer fits, but they keep wearing it. And that denture has a pivot point that ulcerates, and that is where it starts. So patients that have, I ran out of battery, patients that have history of bisphosphonates, you want to make sure that their removable dentures or mouth guards or CPAP devices or repositioning devices are very well fit and don't have any high spots or areas of injury, because if you end up with a pivot point that ulcerates, you may trigger things like that. So this is similar patient. And these patients, as Dr. Cruz sees probably often, we see them all the time. These patients are miserable. This is necrotic bone. This is dead bone. And I'm going to show you one more picture, and then I'll probably wrap it up. I'm going to show you a lot of these pictures of ulcerative patients, but I want to get to somebody like this. This is stage 3 osteonecrosis of the jaw. They're already pussing out through the skin. And this is the same guy. This started with a mandibular torus. that I just showed you. This patient, I'm taking this picture with a Q-tip in my hands, and this patient was about to die. This is the last time I saw this patient, and we had gotten very close with this lady. She was oozing out through her skin here, and you can see how erythematous that skin was. She was miserable, but she asked me to make sure that I taught as many people as I could about this miserable condition to prevent it from happening, because this is what killed her. She ends up with septicemia and she died. But she had a communication from her mouth to her neck, and anything that she ate ends up in her neck. So all of these people that I'm showing you here have stage 3 osteonecrosis, and it started with a denture that didn't fit, an extraction that was done. So look at her tissue here. She also had a denture that had 2 pivot points in an area where there was misfitting areas. Let's finish with a couple of malignancies just to show you some oral cancers. This is oral squamous cell carcinoma, and I want to show you the surface of this lesion and then show you this. This is a different patient, also with an ulcerated squamous cell carcinoma. Sometimes when we have lesions like this, there's a bigger problem than the ulcer, but the ulcer is what brings it to the attention of the patient because the ulcer hurts. Some cancers don't, but when the ulcers hurt, then we have that issue as well. So this is the case I already showed you. Thank you, Kevin. I appreciate it. This is the case that I already showed you that has the ulcerated surface. This is the other case, osteosarcoma of the jaw. This is the Schneiderian papilloma. This is a case of a metastasis. If you saw this patient's lesion, this little guy here, it looks like nothing. Thank you, Kevin. I appreciate it. So this patient has a known history of esophageal cancer. And this popped up, clinically diagnosed as a gingival abscess, but the patient required or wanted that lesion biopsied. It was biopsied, and sure enough, it was a metastasis from his esophageal carcinoma. And another little piece of information, not everything that bleeds is an ulcer. Look at this lesion here, a little granular, and whenever you touched it, it bled because this was a squamous cell carcinoma that had angiogenesis going, and any little touch will make it bleed. So if it doesn't make sense, make sure that you go at it. Now, I want to leave you with this here, which is a little algorithm of how to manage steroids. But probably more important than the steroid part of the algorithm is the first spot, which is you have to start with the right diagnosis. If we don't start with the right diagnosis, if we don't name that baby or have that baby named by something or by a biopsy or by consultation, then we will chase the wrong way. There's one of my favorite books is The Habits of Highly Effective People. And it starts with the concept of somebody working really hard to climb a ladder. And it took a lot of effort to climb that ladder just to find out that at the top of the ladder, he had leaned the ladder to the wrong wall. So we have to start putting our ladder on the right wall. Make sure that you start with the right diagnosis, and then you'll follow this algorithm. You're going to decide if you're going to treat this patient with topical medicine or systemic medicine. And as a rule of thumb, I always use the single, simplest, easiest tool that does the job. I don't want to treat a single aphthous ulcer with systemic prednisone. I will match the lesion and the problem to the tool. So topical, systemic, and as soon as the patient starts feeling better, I will start holding back and tapering back. And when they get a flare-up, we'll go up and down with that. So I develop a long-term relationship with these patients, and they get really good at telling me when they need more, they need less. But this is basically the algorithm. Start, depending, if they have a very significant problem, start with systemic and then taper. Either with a tapered dose pack, Medrol dose pack, or any of those medications, or 1 milligram per kilo. I can go up as high as 2, but I will have to monitor these patients very closely. And once they become less symptomatic or start to respond, you can transition to as needed or to topical. And whenever flare-ups occur, you go up and down based on the flare-ups. In topical medicines, the same thing. I almost never use gels anymore. I mostly use dexamethasone elixir, and I have them used starting 4 times a day for 2 to 3 minutes, which feels like an eternity. But they have to do that, swish it, and then spit it out. And as soon as they start feeling better, you start cutting back to 3 times a day, 2 times a day, and you will be basically matching the treatment to the disease activity, and up to 4, between 0 and 4 as needed. And this is usually how I manage patients with systemic and topical steroids. And all along, I'm checking these patients for signs of candidiasis or yeast infections. If they do, I keep them on the steroid and I add the antifungal of my choice, either systemic fluconazole or topical with nystatin or clotrimazole lozenges. But this is hopefully a quick little summary of ulcers in pediatrics and adults. And now I'm very happy to answer any questions or hear any observations or comments you may have. Thank you very much for being here today. And again, this is my email address. I'm happy to send you the handout if you just shoot me a quick little email, and we'll go from there. Yes, sir.
We're talking about antivirals, or what antiviral is your primary choice?
My go-to antiviral is Valtrex, valacyclovir. Yeah, because acyclovir has a half-life that is a little bit too short, and people will need to take it between 3 to 5 times a day. With Valtrex, I usually get away with giving them 2 or 3 times at the most. And it's basically acyclovir in a prodrug form. As they pop it, their liver unpacks it, and it becomes acyclovir in their blood. But much better half-life. Yes?
Do you ever use the Bactrim or whatever for?
Yeah, I don't use the Bacterol. I'm not allowed to use it at UNC, but I am very okay with that. Once the patients come down from the roof and quit crying, it actually will work. Now, when I endorse the Bacterol, I usually tell people to be very careful and to use it only inside of the ulcer, because if you use it outside, you will create necrosis or an ulcer there. So just cauterize the center of the lesion, and hopefully it's all you touch. But it's okay to use the Bacterol. Yes, sir.
Your oral base B, it's a prescribed.
It's a Colgate product. It's over the counter.
Over the counter.
Yeah.
Okay.
Yeah.
It's still available? Because I mean, I myself have a hard time like getting it. Anymore.
I know my patients get it on Amazon.
Okay.
Oh.
Yeah.
How about Kenalog?
Kenalog and Orabase is also available, but that is a prescription because of the percentage of steroids. So anything above 1%, it will be prescription.
Okay. Do you recommend Kenalogs?
Yes, absolutely. It's okay, but you have to use it like Orabase. It has the adhesive, and so you're going to have to dry the target mucosa first and then use it.
So it will attach to the teeth.
Correct. Otherwise, it will attach to anything that's dry.
Yeah,
And
I remember.
patients end up with this mouthful of stuff.
Gotcha.
Yeah.
What's your thoughts on?
Yes.
What's your thoughts on localized laser therapy?
Laser therapy for aphthous ulcers. I think it's a good idea if you have it available. It works in some patients. It makes worse lesions in other patients depending on the wattage. I don't use it. We have a laser, but I find it much easier to give patients the training and the steroids. But if you need to cauterize somebody's ulcer before they give a talk or they go on honeymoon or they get married, that's reasonable. Yeah, I don't do it, but I know it works just like the Bacterol. It's another tool that I much rather, if I have 24 hours to treat these patients, if I have somebody that's literally gonna go and get married in the weekend and it's Wednesday, I will give them a Medrol dose pack and a tube of clobetasol to apply the clobetasol twice per day for a week, use the Medrol dose pack, and also keep some dexamethasone with them. And it will, within 24 hours, will go from 10 to 2. I don't use laser because I have had bad experiences with triggering other ulcers or a larger ulcer at the end. And I don't have access to the bacterial. Our dispensary ladies don't like it, so I don't get to use it. Thank you. Thank you very much.
Thank you. Thank you. Yes. Well, thank you, everyone. And as well, I'm very happy to have the Prudential students from UT, Rio Grande Valley here with us, and hopefully other students in San Antonio and Houston that were able to listen to this lecture today. We'll happy to have you hopefully soon with a different, two other speakers that we want to have with Dr. Padilla, and hopefully we can get them, combined pathologists and hear their opinions. But this is a great topic. I treat ulcers all the time. I myself have a history of minor ulcers, and it's hereditary. It comes from my great-granddad, my grandfather, my dad, and myself. At least we have tracked males. And I get little minor ulcers on the tip of the tongue, and I use Kenalog, the same technique that you use. And that's why I tell my patients, when I get patients referred to me, that's typically what we use. But most of all, I really want to thank you because you cover pediatric, you cover adults, you went from minor, major ulcers all the way to cancer, and you touch, biphosphonates, which is, the medical induced osteonecrosis of the jaws that we see very often with those patients that we're treating now with biphosphonates, which is very common that you guys know, and I really thank you for that. It's really an honor to have you with us. And
It's an honor to be here.
Thank you. And
Thank you for sticking around, everybody. We figured out the technical difficulties. Thank you, Kevin, for fixing that. We appreciate that.
All right, thank you, everybody. I have your CEs here. You do need to fill out a survey in order to get a CE. So please do that. They were out there on the table, so you can grab them right quick. And remember, we have one more meeting to finish out the year in May, so we look out on your emails and texts and everything for that, for the May meeting. So thank you, guys. Have a great night and safe.